Hi, everyone. My name is Alexander Lubichansky, and I work at the Soviet Medical Library, University of Nevada, Reno. We have all heard the phrase, can't see the forest for the trees. But what if our entire approach to evidence-based practice is doing just that, zooming in so tightly that we miss the bigger picture? Today, we'll explore interesting ideas about updating evidence-based practice proposed by Edmonds, Cullen, and DeBerg in their article, The Problem with the Pyramid for Grading Evidence, the Evidence Funnel Solution. The article was published last June in the Journal of Peri-Anesthesia Nursing. This is, by the way, a fifth article in the series that are calling for revolutionizing processes for evidence-based practice, particularly in nursing. It critiques our beloved evidence pyramid and proposes an evidence funnel as a more holistic alternative. Well, levels of evidence, as we know, sometimes visually presented as an evidence pyramid that we all know. And the evidence pyramid has become entrenched in evidence practice education. And the pyramid that we're using typically will place research designs that have more internal validity at the top. In this case, randomized controlled trials, meta-analysis, systematic reviews. Now, internal validity is related to the extent to which systematic biases are reduced. For example, a randomized controlled trial has more internal validity than non-randomized trial because bias occurs when participants self-select which study group to join. So authors of the article argue that while this hierarchy of evidence represented in pyramid does value internal validity, it ignores context, patient preferences, and real-world feasibility. So in their article, they use this representation of the pyramid. And as you can see, they show here qualitative research just above animal research, so somewhere at the bottom. I prefer this version of pyramid because it's more colorful. It's from Himmelfarb Library. And if we will be thinking about qualitative studies, they'd be somewhere here together with case reports. Now, what is their core argument? What problems with the pyramid they are seeing and they're bringing to our attention in the article? Well, their main criticism is that, first of all, focusing on high-level critical appraisals and experimental studies at the top of the pyramid is like using the lens to zoom in and bring high-level fine details into view. However, what happens if we zoom in too tightly, we lose sight of the overall picture, or in this case, the body of evidence. So they're telling us that we zoom in and we can't see the forest for the trees. Their second criticism is that a major shortcoming in the evidence pyramid is linking quality to internal validity, when evidence-based practice requires external validity for application. Remember, external validity is the extent to which the findings of a specific study can be generalized to other settings. Randomized controlled trials often have limited external validity for actual practice, right? For actual clinical practice. So authors tell us that pragmatic trials and observational studies are needed to determine which interventions are effective in real-world settings. The third criticism This further is exacerbated by the fact that 40% of nursing studies do not clearly report trial design, and that makes placement on the pyramid very ambiguous. And the fourth, they argue that prioritizing clinical trials over qualitative research excludes key evidence that makes the evidence-based practice change effective in practice and applicable for patients. So they're calling on us to revolt against ranking evidence within hierarchy. So what are the resulting gaps in their opinion? What gets missed? Well, they're telling us that patient experiences and values are getting missed. Insight into side effects, feasibility, unintended consequences, as well as evidence from diverse populations, which is often excluded in tight control trials. On the other hand, they say that overuse of pyramid leads to biased decisions and rigid protocols. So their question, they ask the question: are we building protocols and clinical guidelines for patients or for the pyramid? Now they propose solution to these problems. They propose solution and they suggest two-phase model, a step-by-step approach to building full picture. They suggest actually 8 steps, and I will summarize them a little bit. Bottom line is you start broad with background and guidelines. Then you examine prevalence and risk factors. And as you notice, I put in brackets there, cohort studies or descriptive. So this is actually reflects their opinion that we should be looking more at the observational cohort studies. The third, look into patient experiences and psychometrics. And only then, only after that, you review interventions and trials. And you finish with synthesis through systematic reviews. In real life, we usually start with systematic reviews, remember? So this is part 1 or phase 1. Now we are ready for phase 2, which is turn the evidence pyramid upside down, as on this picture, and create evidence funnel. So let's see on a little bit larger picture how it works. So the evidence funnel, they tell us that evidence funnel brings us through critical appraisal to minimize bias and confounding. So we include we include external validity when considering the quality of research studies at the very top of funnel. Now look from the perspective of the body of evidence. What is the quantity and consistency across the body of evidence? So this is second layer. How many studies? How large are the samples? Or how large of an effect is found? Then you determine how strong, here you are, you determine how strong is the recommendation or expected benefit or impact. Then you determine certainty of benefit by weighing consistency of results across the body of evidence and the likelihood the recommendation will change and another practice update will be needed. So you have to determine that. then evidence recommendation needs to be localized or adapted to fit local context. And that leads to your practice change. They give us a hypothetical case. I think it's hypothetical, but maybe it's a real one. And they call it real world application. The ICU case, it's a story of a Sarah who is a nurse in a medical ICU. She sought to improve pain management communication for ventilator-dependent patients using evidence-based practice. Initially, Sarah searched PubMed using filters for clinical trials, systematic reviews, and meta-analysis, finding few records that seemed relevant. However, remembering that the clinical trial filter can be too narrow, Sarah broadened her search and discovered an observational study that highlighted the high prevalence of fear in ventilated patients. And fear is an important factor exacerbating pain. So what did she do next? By the way, this study that she found also provided strategies for addressing fear from patients' perspective. So what did she do then? She modified her search in CNAL to include patient satisfaction and patient reports as outcomes. This approach led to additional non-randomized studies, which offered further insights on both effective pain management and communication strategies tailored to patient needs. Bottom line, they're using this example to tell us that the pyramid would have left her with a very narrow and incomplete view if she followed strictly our current guidelines in searching for evidence. So what are the key takeaways in this article? Well, it's time that they think that it's time for evidence-based practice teams to update how they review the evidence for practice recommendation by weighing all types of evidence similarly and not categorizing evidence according to what they say, quote unquote, an unhelpful evidence hierarchy. So they think that levels of evidence and its associated evidence pyramid lead clinicians to prioritize evidence that may not and often is not practical for use in real world setting, and that it leaves out the perspectives of patients and the impact for diverse patients as well. So they recommend that we use sequential strategy to review and synthesize all types of evidence. Why? And they say use funnel. Why? Because it's more inclusive, more realistic, more aligned with real world care. I don't need to remind you, of course, that patient values are included in our traditional definition of evidence-based practice. But unlike high level of evidence, here they're saying, as you can see, true evidence-based practice must include best available all type evidence. That's something new. So what is their conclusion and call to action, judging by this study, by this article? Well, they challenge all evidence-based practice teams to see the forest, not just the tree, right? They really calling on us to turn pyramid upside down and use an evidence funnel instead. So it seems that they're recommending educators to rethink how we teach evidence-based evidence synthesis. Clinicians probably should broaden their lens beyond randomized controlled trials. And researchers probably should be designing studies with external validity in mind. And bottom line, to be open to reforming traditions that no longer serve the patients. Now, what are my own thoughts after reading and analyzing this article? I grouped strength and limitations here. So the strength of the article, in my opinion, is the relevance of topic. I think article addresses crucial issue in evidence-based practice. See, grading evidence is a fundamental part, right, of clinical decision making. And traditional pyramid model has long been used to assess study quality. We all know that. However, we also probably notice through literature that there is increasing recognition that pyramid sort of oversimplifies evidence, and it does ignore key aspects like context and sometimes even methodological rigor of studies. So from this point of view, the topic could be considered timely, as particularly if you think of the complexity of healthcare, and healthcare is growing, and there is a push for more personalized, patient-centered approaches to care. So from this point of view, I think it's quite relevant. This funnel business, this evidence funnel concept offers innovative and kind of a fresh perspective, unusual, right? The funnel allows for a broader scope of evidence to be considered. So I think it's quite innovative. It does recognize that not all evidence can fit neatly into a tiered pyramid system. So in essence, they promote more flexible model. They encourage a more inclusive approach that encompasses high level and low level studies. Article was written quite clearly. I think it was pretty easy to read and understand. So it made the complex issues and ideas to grasp kind of a quite quickly and easily. What else? Well, the emphasis, of course, is on practical application. The authors didn't just present a theoretical critique. They also addressed how the funnel could be applied in everyday clinical practice, and they gave us those 8 steps, remember? They really convinced that this funnel model can better accommodate the complexity of patient care. However, I found some limitations, and this is my personal, of course, my personal opinion. One key limitation of this article, in my opinion, is the lack of empirical data to substantiate the effectiveness of this funnel compared to traditional pyramid system. Their theoretical arguments are quite compelling, I must say. However, I didn't see them presenting any concrete examples of research or research findings other than that little story about Sarah. it would be nice to see some research findings that would kind of demonstrate the funnel model leading to improved clinical outcomes or decision making. So this was this kind of a maybe was one of the weaknesses, or I would say limitations. Another thing is, even though their funnel is very innovative, funnel approach is quite innovative, and it aims to be more flexible, I can see that it may still be kind of oversimplifying the complexities that are involved in evaluating evidence. I suspect that, I should say, I strongly suspect that the funnel may not be immune to the same pitfalls of subjectivity that they accuse our traditional pyramid of, especially in interpreting the quality and the relevance of studies. For example, the process of filtering through evidence in a funnel may still involve quite few biases or inconsistencies that could or would undermine the effectiveness of this new model. So I kind of suspect they'll be there. Another limitation could be a potential for misapplication. In other words, without clear guidelines on how to apply this model, I can see some people might misuse this funnel to prioritize low quality evidence for one simple reason, that it's contextually relevant, right? If people will really concentrate too much on context, it will be very tempting to overuse it. And again, it will lead to the same issues of misinterpretation that our current pyramid was criticized for. Another limitation, I think, is limited scope in addressing broader systemic issues, such as, see, they talk about grading system and all the levels of in the pyramid, but they don't address things like institutional support for evidence-based practice, funding for research, time constraints in clinical settings. So those are all kind of systemic issues that probably would be of importance if you really want to encourage big changes in evidence-based practice. It's a promising alternative, of course, based on their article, but does it address practical barriers to utilizing evidence effectively in the real world? I didn't see that. So the big question that I have, does considering a broader range of evidence lead to better patient care and outcomes? Or does it risk overwhelming practitioners with conflicting or lower quality evidence? Maybe somebody in the audience can answer that question and provide some evidence if there is any. That's my big question after reading this article. But overall, I think it's kind of a refreshing approach. And if you'll be reading this article, read their other articles in this series. They take on PICO formula and other things. That's very interesting. So I guess we have a few minutes for questions, but rather than hearing questions from you, because I probably wouldn't have any answers, it would be interesting to hear people's comments. And before I stop sharing, I will show you this slide. That will have a break in in the workshop presentations until September. So save the date, September 23rd. There will be compliance with embargo. So I'll stop sharing, and maybe people have some interesting insights or some ideas. Remember that, okay, where is video? Remember that there were many other, oh, you disabled my video, Karen.
Oh,
I was trying to
I
click.
didn't mean to disable it.
I wanted to show my face and you don't want me to.
Okay. No. During the recording, I turn it off.
Yeah, okay. What I want to say is that I've seen other articles, by the way, and there were quite few new models suggested for pyramid. And in one particular article, I think it was one of the surgery journals, they were they also were bringing to the top observational studies and saying there's lots of good evidence there that we're not using. I don't know, maybe people have some interesting comments.
One comment says that maybe there has been feedback on the literature. Per Scopus, 3 articles have cited this one.
Mm-hmm.
So it's being.
Oh, so there is some movement, yeah.
Mm-hmm.
That's interesting.
I definitely can see there's a place for this that, like the article explains, in my opinion, from my years, that especially the patient perspective.
Yes.
Because I think that gets lost when you try to make it all hard data.
Right.
You know,
right. And remember, Karen, in RCTs, this is all pure science, right?
Yeah.
But they're valid. Lots of treatments are based on that. But if you deal with down-to-earth hospital nursing issues related to patients, like there's no way you can you can do RCT that will tell you this is what patients feel, this is what they think, and so on. It's kind of a
well, and in the EBM, when we teach here at CHSU, when we teach them how to like critically appraise a clinical trial or a randomized trial. The drug that we're looking at does show that it's better than the standard medication. But one of the things I like to point out when we go to the EBM part is it's still a brand name.
Yeah.
Not every patient can afford it. So you go, oh, okay, so this looks better. You prescribe it to your patient and the patient can't afford it. And now they don't have the previous drug and they don't have the new drug and, stuff to, hopefully get them thinking for the future. So.
But it's interesting approach. I mean, the only trouble is a little trouble, as I said, and limitations is all good ideas and fresh ideas have some merit to them, but when they start developing them, they start discovering all kind of issues there. But it's worth to try.
Feel free to unmute if you want to ask a question via audio, or if you're having an issue, let me know. You should be able to unmute yourself. Because we've still got quite a few people here.
Anybody has any input, any ideas?
Well, not a question, but just some commentary. I've been looking at this series very closely, and also the Johns Hopkins model is making some changes.
Right.
And I think it's important to remember nurses do different work from doctors.
Yeah.
And evidence-based medicine and randomized controlled trials are really set up for treatment with prescribing drug A or treatment A versus treatment B. And nurses are often doing more of, at least in my experience where I work, they're kind of looking at overall big practices and policies. How do we work with heart failure patients generally to reduce readmissions? Not so much this particular one patient in front of them, but the class of heart failure patients. So I do think some of these new ways of looking at asking the question can be helpful, because sometimes nursing questions don't fit into the PICO format very well. I also find, and I think, as you said, Alexander, this will become an issue down the road if we were to move to this funnel approach. Something I'm often running into, not just with nurses, but with other allied health staff, is it's been hammered into them that randomized controlled trials are the top of the evidence pyramid and really the only thing of value worth looking at. And so if they have a question and there are no randomized controlled trials that address it, they just want to discount the rest of the evidence.
Right.
And sometimes we have to explain that, you can't really do an RCT for this particular question. And I think that gets lost sometimes in their education and training. And the other thing I've run into and often challenge nurses with is they'll send a request to me to search and say, oh, I only want to see systematic reviews. And I'll say, oh, why is that? Well, those are the top of the pyramid. Yes, they are. But
Because we taught them to do this.
but yeah, what if the latest systematic review is 3 years old? Don't you want to see studies published since then? And so it is kind of that ongoing discussion. And I think we all like to rely on rules to make life easier and to eliminate some of our decision making. And I think, as you say, we can run into some of the same things if we flip over to this funnel. It's kind of that ongoing conversation that there are general rules, but a lot of things aren't going to fit those rules.
Right.
I totally agree, Francis, that I think it kind of needs to be a both and. It's like there's places to use the pyramid
Yes.
and places to use the funnel, because there are also issues sometimes where reviews are like, oh, there's no clinical trial on this thing. And it's like, yeah, because it's not ethical, because the population is so small, or the population, maybe in, mental health. And there's some places where it's not just is it not possible, it's not ethical to do a clinical trial. But that doesn't mean we haven't tried to treat these people and we haven't published stuff on them. I've seen that happen too.
Yeah, we see that a lot in like physical therapy and occupational therapy, that there aren't really randomized controlled trials, but people have published reports on how they have tried to treat patients.
Right. I see the comment from somebody who does, who works in a social work, I think. Well, you're right. Nursing is more advanced, but even within nursing, I remember I was we had discussion in the journal club, nursing journal club, and the nurses said, how come every time we find some good article on nursing practice, it's from Australia? I said, because you guys don't want to do something yourselves. I mean, it's evolving. Things are evolving, and they're more advanced in that way. And the same will happen to social work. I'm sure you will. And you mentioned occupational therapy and physiotherapy, and that's very interesting, because I noticed the same. I made the same observations in the hospital here in Reno. They want to have some tangible evidence, but there's not much in their field. And they want to see only the top, the best. You're right. That's how we condition them.
Yeah. Well, the other thing is, as someone, I spent over 20 years in hospitals previously. Our nurses are not given any protected time to do research, but they're expected to base everything they do off of research.
Right.
Whereas if you are an academic practicing physician, you do usually have to do research in order to keep being an academic. And during residency, they have to do, scholarly activities. That isn't something, I mean, the number of nurses I've encountered over the years who would love to be able to really dig into a topic and research it. And they're like, we don't have the time. We don't have enough nurses on the floor.
Well, forget the time. Many hospitals close their libraries. They don't have elementary
Yeah.
support there.
Yeah, that's why I'm not in a hospital anymore.
Exactly,
Yeah.
exactly.
So Devin,
But context is important. In that I agree with the authors, like context.
yeah.
And this is, I think we should have several pyramids or funnels, not just one.
Yeah, yeah, that's actually a good idea. So Devin's bringing up that the OTs at her institution have coursework on historical unethical studies. Yeah, that's so important in any type of healthcare education that
Right.
yeah, as an IRB member, the stuff that we've done in the name of health care sciences.
Well, but that's how in olden days science developed. They would drill people's skulls, to look inside what's
Yeah,
inside their brain,
yeah.
You should read the oldest issues of New England Journal of Medicine. You'll be shivering. That's it's if,
Yeah.
luckily it's kind of evolving to more ethical and other things. But anyway, let's my approach is I'm not ready to discard our traditional pyramid yet. And but I'm open-minded to look at some other options. It's very interesting. And I made a point that it's particularly emphasis here is on nursing.
Hmm. Yeah.
Well, thank you very much. If
Yeah, I
there are
don't see
no
any
other,
further comments. Any last comments? I know we went a little over, but I think people were enjoying the discussion.
yeah,
Um,
there's so many new models coming up, and on one hand, people are challenge the past kind of fossilized or established uh, practices
mhm,
and theories, but when you bring the new, it shouldn't be just for the sake of change. It should be for the
for,
sake of usefulness. Yeah.
yeah.
Thank you, everyone, for attending.
Yeah, thanks everyone for attending. We had great, so thank you very much, everyone. And again, this will be up on YouTube later. So, all righty, bye.
Bye bye.